and welcome to Alzheimer's Speaks Radio. I'm your host, Lori LeBay, and I'm so excited that you're joining us today. We are going to have a fascinating conversation as usual as we learn from people all around the world at all ages and stages of life. Stay tuned as we shift our dementia care from crisis to comfort.
Here we go. What you think about, you will bring about the mental change. We will.
Well, hi, everyone, and welcome to Alzheimer's Speaks. I am so excited that you're joining us today. We're going to be talking about, does our immune system hold the key to treating Alzheimer's disease, which I think is pretty fascinating. But before I introduce you to our guest, I always like to give a couple of shout outs. One, I really encourage people to go to our main website, alzheimersspeaks.com. There you will find one whole tab that is all about free educational resources. So please check out that and take advantage of those. Feel free to share those with everyone and anyone. That's why we have developed all of those. Also, you'll find our book tab. There you will find our book, Betty the Bald Chicken, which is on lessons on how to care. It's really about opening up the discussion when you don't feel like you belong or you fit in anymore. And it's written as a children's book with some great questions, but conversations just blossom with all ages and stages. We've been getting wonderful feedback. And then the last, I just want to encourage you also to visit Dementia Map, which is a global resource directory, and that is available for free. You don't have to give any personal contact information. There's over 150 different categories you can search. There's an events calendar, there's a glossary of terms, there's a shop, and so much more. So check out dementiamap.com as well. So let's go ahead and introduce you to our guests. Well, I'm so excited, like I said, to have this conversation about the immune system and dementia as a whole with you today. So Tommaso, I'm going to have you first introduce yourself if you don't mind.
Sure. So I'm Tommaso Croese. You can guess from my accent that I'm definitely from Italy. I did all my clinical studies there in Milan. Then I did a PhD in neuroimmunology. Maybe we'll have time to say more about it, why I was always interested in the immune system in relation to neurological diseases. And then not so recently anymore, around 1 year ago, I joined ImmunoBrain, in which I'm working as the medical director, and we are working very hard to try and develop an immunotherapy for patients with Alzheimer's.
Wonderful. Thank you. Well, I always start my first question off with asking all of my guests if they've been personally touched by dementia in their own family or circle of friends.
I should say not in my family, but actually I was touched by dementia in my clinical practice, and definitely it's not the same when you experience it on a relative, but it's really one of when I really saw the impact that neurodegenerative diseases such as Alzheimer and dementia had for other people's lives. I really felt that there was a lot of work to do specifically on this field. So actually I started my clinical practice focusing on other neurological disorders, but then I felt compelled to do something specifically in the field of Alzheimer's.
Wonderful. Now, you had mentioned, maybe we'd have time to talk about this, and I think we will. Why don't we start with what drove you to become interested in science and medicine and the immune system?
In medicine, I honestly don't know. I think it was just a good call that I had when I decided first to start medicine. And I think it's the most rewarding profession that one can have. So I'm very glad that the decision that I took when I was 19. About the immune system, there actually was a sentence from a great genetist and oncologist from Japan, is based in the US. He said that medical scientist has two lives, And the second one believes when they understand that the immune system is the orchestra of all life symphonies. I hope I quoted it correctly. And really, while delving deeper into my studies, I really realized that both the brain and the immune system are fascinating because in a way they can really control all other organ and function. But we didn't really know, and we are now understanding better how they interact with each other and how each one of them separately and together can affect not only brain function, of course, but also all other organ and systems. So, we have immune cells in every single organ of our body. And the brain is also connected and control all other organ of our body. So that's what was raised my interest in the first place. And that's why I decided to become a neuroimmunologist.
Wonderful. Well, and we seem to be hearing more and more about the immune system. I mean, I think, my mom lived with dementia for 30 years. She's been gone for almost 10 now. And back then, I mean, nobody knew really anything about anything as far as, what we were told, publicly. And it seems like it's starting to explode and expand more and more. And it makes sense that the immune system would be the one orchestrating, kind of life within our body, like you said with that quote, because it's key. And so I'm so glad, like I said, to have you on the show to be talking about this today. Let's talk a little bit about the newest science in the field of Alzheimer's and dementia research. And I should ask, is there a difference between just Alzheimer's research and dementia as a whole? Because a lot of our audience doesn't understand, the differences there.
Sure. So let me just do a step back. You mentioned that 30 years ago, no one knew about the influence of the immune system. I think it's actually even up to 10 years ago, 15 years ago, when we talked about the immune system in the brain, specifically within the brain, we always thought that they were mediators of damage. They were responsible for autoimmune disease in the brain. Maybe someone heard about multiple sclerosis or other autoimmune disease. So the immune system within the brain, really until recently, we always thought that they are the bad guys. But it doesn't make sense. And because, as you said, the immune system is an integral part of our body. And we need it not only to fight infections, for example, but we need it also when we need to recover from a damage. So even a scar in our skin, we need the immune cells there to control that the repairing process are happening in the proper way. So this was what led the research from Michael Schwartz to start investigating a way to exploit our immune system to our advantage, even in the context of brain pathologies. So it's something that is really evolving very fast and started only recently. And we really see more and more scientific publications that show the crucial role of the immune system for brain repair and function. About the other question, what are the differences between Alzheimer's and dementia? It's not an easy one, but definitely there are differences. And this definitely also impact the therapeutic landscape of these conditions, right? Because we know that most of the outcome is the loss of brain functioning, right? Our brain is either the memory is not working as good as before, or patients, we start to develop cognitive symptoms or even behavioral symptoms, but the root cause behind each disease is different. So for example, in Alzheimer, I think right now we all know that amyloid beta is there, and it's definitely part, or maybe even the trigger to a cascade of events that then lead to loss of neuron and loss of function. We have other form of dementia in which we don't have amyloid, but still we are losing neurons and still we are losing function of the brain. So when we should consider these when we think about the potential therapies, and this is actually one of the, in my opinion, the strongest points of what we are trying to do now. The immune system helps to fight any type of damage, right? So if it's amyloid, the immune system can help to limit the spread of amyloid. But also if we have another form of damage in the brain, the immune system has the potential to fight also all aspects of the pathology, not only a specific feature of the disease.
Wonderful. Thank you for defining that. Now, as far as newest science in the field, there's been a lot going on with these new drugs and different things. What are you seeing are kind of the newest types of sciences that are being looked at?
When you say the new type of science, I think we should distinguish what is the basic science from what is the clinical trial, so clinical trial are definitely bringing us closer to find the therapy. It's where we really test what was developed in basic research, and we can talk a lot about it. I think it's an extremely exciting time. And then there is the basic research, right, that usually precede the clinical trials of several years or even decades. So on the basic research point of view, we see that there's a lot of interest in finding new potential way to target Alzheimer's disease, and not only Alzheimer's disease. And the more we understand the disease, the more we will be able to develop additional treatment option. And also something that I think it will be interesting to discuss together is the idea of personalized medicine. I really believe as a neurologist, as a physician, that each patient has its own characteristic. We won't have the magic pill that will apply to all patients, right? Because each patient has its own peculiarity. When we talk about clinical trials instead, definitely the most recent results from phase 2 and 3 clinical trials with two anti-amyloid antibody. I attended the AAIC conference, the International Alzheimer Association conference that was in July, and I was very excited to see these results, I'm honest, because there was a lot of skepticism before in the past. And we now, for the first time, I would say, we have something that show promising data. It shows something that we can actually do something on the pathology itself. And I think that if we arrive at this exciting stage, it's also the Patients Association, for example, had a big role on this, because they really managed to pressure the scientific community to work in this direction. So we are in an exciting time. The results that were recently published are definitely promising. There are several considerations that we should make on this specific trial, but I would personally prefer to focus on what we are doing, and rather than to dissect results that were already published. But definitely we are in an exciting time right now for Alzheimer's care.
Okay. Well, I just wanted to bring it up because I still hear so much conflict in terms of what people believe regarding, the latest two, medications that were just, authorized and stuff on that. And so I always find it interesting. But let's talk about, your work and what your focus is. So why do you think it's important to kind of continue to dive in to develop, additional types of treatments for Alzheimer's and dementia?
Sure. So as I said before, each patient has its own peculiarity, and even the recent trial that were published, for example, they show that the earliest you treat the patient, the better it is, right? So this will cover, I think, right now, just a portion of all the patients affected with dementia. And our goal should be to propose and suggest something alternative, or to provide several options to patients that can try to give all of them hope to fight with this disease. So we need really, it's important when we do clinical trial, definitely, that we identify our population of interest, to reduce variability, to have an homogeneous population, and to really delve into details in a specific target. But when we move to real life, things are different, right? So we don't do all the screening assessment that are done in the context of a clinical trial. So we always need to think that we always need to broaden the population that we can target. So I think that's why we need to definitely keep working, investigating, and developing a new drug. What we are trying to do in a simple way, and as we said before, is really to ask our immune system to do the job for us. I said before that the immune system helps recovering from any type of injury, including brain injury, but with aging, which aging is also one of the major risk factor for Alzheimer's disease, our immune system become less efficient. And there are other studies that even shows that if your immune system is aging, all your body is aging. So what we are trying to do by using this molecule that is called immune checkpoint inhibitor, we are trying to rejuvenating our immune cells. We give them a boost, okay, so that it will induce them to migrate into the brain and to cope with the pathology. And what is the major advantage? We said before that probably the two most promising results that we saw were with two anti-amyloid antibody, but they target amyloid. And we know that Alzheimer's is a complex disease. Even without entering into other dementia, Alzheimer's itself, it has several features. We don't have only amyloid. We have neuronal loss. Another feature that is crucial for brain functioning is the brain inflammation. Usually in the brain of a patient with Alzheimer's, we have an inflammatory environment. We have more specific cytokines, specific molecules that contribute to the loss of neurons. So anti-amyloid targets specifically this pathway, while the immune system is able, and it was shown by scientific papers published by Michal Schwartz's group, that simply by rejuvenating and boosting the immune system, we are able not only to reduce amyloid, but we are only able to reduce tau pathology, which is another protein that accumulates in the brain and is responsible for the neuronal loss, the loss of function. And we are also able to reduce the brain inflammatory environment. And I understand that it might sound counterintuitive. You boost the immune system, but you reduce inflammation. But that's what happened because we boost the immune system in a controlled way, and the immune system knows how to react. The immune system it's extremely variegated, so we don't have only pro-inflammatory cells. We also have several cells, such as regulatory T cells, that actually help to reduce the inflammation. And it was shown that by using the approach that we are using, we are increasing the number of these cells called regulatory T cells within the brain. And this is part of the mechanism of action of what we are trying to develop.
It's interesting when you said about reducing inflammation, because I honestly can say I've never heard anybody say that the brain gets swollen. We're always hearing about the shrinking of the brain. And so when I think of inflammation, I think of swelling. And so to me, when you said that right away, there was a contrast like, wow, I never heard that. And I remember when my mom, we did an autopsy on her brain, and the neurologist actually, he was just shocked. And he made a comment, and he's like, I've never seen a brain this small, he said, but if someone's lived with it for 30 years, this is exactly, what we should see. And so thank you for saying that, because I didn't really understand that. If I have heard that before, I don't remember. It didn't stick until just now when you made that comment. For people who are just tuning in right now, we are talking with Tommaso Croese, who is the medical director for ImmunoBrain Checkpoint. And we've been learning about not only a recent research in the field, but he described kind of the differences between Alzheimer's and dementia. We're learning about kind of basic science and the importance of the study of the immune system and why it has such a big, powerful impact not only on our brain but our whole body altogether. and that this is really new. Only in the last 10 to 15 years has it really been taken seriously and being looked into with some cool outcomes. We're going to learn a little bit more as we talk with him, but I just wanted you to know, if you just popped in right now, that you're going to want to rewind and probably hear what Tommaso has had to say. And I also want to encourage people to go check out their website, which is ImmunoBrain.com. And you can also find them on LinkedIn as ImmunoBrain Checkpoint there. So, Tommaso, let's get back. I want to talk about your role as the medical director for the company ImmunoBrain Checkpoint, and want to know, how you are approaching things and kind of where you are with studies and so forth at this point.
Sure. I'm sorry, I'm doing this a lot, Lori. Can I go back to your point about inflammation, the brain reducing the volume?
Absolutely.
Just because I think it's a very interesting point, and it might be helpful for everyone to understand it better. Definitely the brain of a patient with Alzheimer, an individual with Alzheimer, is shrinking, okay? Because we are losing neurons. Neurons are dying, and neurons are probably the main cell within the brain. But at the same, so when I talk about inflammation in the brain, it's something that it's more subtle, okay? We shouldn't associate inflammation with swelling. It's two different aspects. And for example, we know from other neurological diseases, I mentioned before multiple sclerosis, which is an autoimmune disease of the brain, in which we have a pro-inflammatory reaction there. If we have a treatment that is able to stop this inflammation, actually we see that the brain is slightly less swollen. So, and the same, it's something that can happen in the context of Alzheimer's disease. And there are actually interesting data about it also in a recent published trial with anti-amyloid. So, but I think it's a very good point. Thank you for raising it, because it might sound counterintuitive.
Well, thank you for defining that. I really do appreciate that. So,
that's why I'm here. I'm trying to do my best. And about my role, where we are with the ImmunoBrain. So we are now, I would say at the beginning of a phase 1 clinical study in patients with Alzheimer's disease. So it's the first time that we test this approach in individuals affected by this disease. We are targeting individuals at an early stage. And we are really trying, first of all, to understand if this approach of harnessing the immune system to fight with the pathology is safe. Safety is always our first concern when we are in front of the patient. First, we shouldn't harm them at all. So right now we are focusing on the safety of our approach. And this is a complex study in which we are trying different dosages of the drug as well. So hopefully it will allow us to identify what is the recommended dose for then going ahead in the clinical trial, phase 2, phase 3, and test it in a much higher, broader number of patients. But we are not only testing safety, we are also looking a lot into disease biomarkers, to see indeed if we are able to induce the effect that we expect. And as I said at the beginning, we have two targets in our study. Definitely the final outcome is the brain. So we are targeting the brain, but we are targeting it indirectly via the immune system, and the immune system in the periphery. So we are checking actually the effect, our first target in the periphery, in the blood. So our immune cells in the blood, and we are also checking the effect that we are inducing in the brain. And for doing this, we are using several different techniques. We really try to stay at the state of the art with many readouts as possible. So we are using not only cognitive tests, but we are also using blood biomarker, CSF biomarker. There's a lot to say about biomarkers in Alzheimer's. It's a very expanding field, and it can really help a lot physician to identify and stratify patients. So it's a very important area of research. And the fact that we have two targets prompt me to also say something more. Alzheimer's disease, it's a complex treatment. It's a complex disease to target because the brain, and this is my personal opinion, but it's probably the most valuable organ of our body. So it's also very much protected. We have a lot of structures that shield the brain from something that can occur in the periphery, right? So we have not only the skull, we have the blood-brain barrier, which is a specific barrier that separates the brain from the blood and doesn't allow molecules from the blood to just cross into the brain. And we have the meninges and several layers of protection. These actually represent an issue when we want to target the brain, right? Because if we inject an antibody in the blood, around 0.1%, more or less, will be able to actually get into the brain. The approach that we are using on this specific aspect is different because we don't need our drug to get into the brain. We need our drug to get into the immune cells, which are in the blood, in the bone marrow, all over. It's very easy to reach immune cells. And then they are the one basically entering into the brain. And it's well known right now that immune cells have the ability to enter into the brain, and they will be the one doing the job, as I already said before.
Well, that's exciting. That is really, really exciting. I had one question. You had talked about you're kind of targeting early stage. Can you define for our audience what early stage is? Because everyone has different perceptions of that.
Sure, and I can understand why. We can simply say, give some number and base our observation on cognitive scale, probably people affected by the disease directly or through their relative, they heard about the mini-mental state examination. So it's a very common and widely used cognitive test. And in our trial specifically, we have a range that is between 20 to 28, right? But on top of this, we are also addressing patients in the stage that it's called mild cognitive impairment, MCI, which I'm sure most people also heard about it. These are patients that we know that they have all the features of Alzheimer's disease, which means that they have signs of amyloid and they might have signs of also tau pathology, but they are still fully functional. So they have memory issue, but they are not strong enough to impact the daily life such in a way that the individual will not be functional anymore. So we are targeting this type of patients. We are targeting MCI, but also patients that are already in an Alzheimer's disease, that already fulfill the Alzheimer's disease diagnostic criteria, but still in an early stage.
Okay.
So
Yeah, and I know the whole diagnostic thing is difficult too, because I can tell you, and I'm not a doctor, I'm not a nurse, I'm not a medical professional, but I know plenty of people that are walking around with an MCI diagnosis that it does affect their everyday life. They're not able to work, they're not able to do a lot of things. And so does that complicate it then, or do you do your own assessment of where they're sitting? Because I know there's a lot of people, and I believe though there's a lot of people that would agree with me on this too, that are misdiagnosed out there.
Definitely, and that's why biomarkers become more and more important, something that I mentioned before, right? Because it's not always easy to rely just on cognitive tests, because it's subjective. Imagine also the complexity for a physician, a neurologist, to visit the patient for the first time. He doesn't have the whole history, and we have days in which we feel better, we perform better, and even in the cognitive test, it might look that we are not that bad, but actually our everyday life is much more complex. So I agree with you. It's not always an easy diagnosis. That's why, especially since the 2018 diagnostic criteria, what physicians are trying to do, it's really to have objective measures. So now you need to have evidence of the position of amyloid. you need to have evidence of tau pathology, right? So to make sure that at least the pathogenic process in the brain is clear. And then when we really go to case by case, person by person, I understand that it's complex. And that's why I think also a crucial aspect of the care for Alzheimer's disease patients is in the care partner. So, and that's why, again, it's such a disruptive disease in a way, because it's really not affecting only the subject that is affected, but it affects the entire family, because the patient really needs to have the support around him, around her. So yeah, and the diagnosis, it's not always easy, as you just said, Lot.
So I have a question, and if you don't feel comfortable answering this, I understand. But like with, you had just mentioned that they really want, kind of the tau or plaque to be present, and yet the NUN study kind of kiboshed that you have to have the taus or plaques, in order to have Alzheimer's disease. Am I mistaken on that?
No, that's correct. You need to have amyloid and tau to be diagnosed with Alzheimer's disease.
But yet there were people in the NUN study that they said people who had taus and plaques that didn't have any issues, and people who had issues that didn't have taus and plaques too.
Sorry, I probably misunderstood your question in the very first place.
So I'm kind of confused how that has to be when that was a huge study over a long period of time that kind of disproved that.
So it goes back to one of the first things I said in my interviews. Human beings are very complex, and I think there is a study that shed some light on what you just mentioned. It was published in Nature Medicine probably more than 1 year ago, but it's recent, and it really showed that the best way to understand the risk of developing cognitive impairment, cognitive loss, is not by looking at amyloid alone, not by looking at tau alone, not even by looking at both of them together, but looking at amyloid, tau, and microglia. And overall, to simplify, we can say brain inflammation. And with this, I want to say something that I already mentioned. It's a complex disease. It's not only about amyloid. It's not only about tau. I'm not that surprised of what you just mentioned about the NUN study with this discrepancy. To me, it's not a discrepancy. To understand the impact on the brain functioning, we cannot look only at one feature of the disease. And this study that I mentioned in Nature Medicine really showed that it's about the three of them together. It's about microglia activation, which is a reflection of the brain inflammation. I can say more about microglia if you want. It's about tau pathology, and it's about amyloid by all the three of them together. And it's actually something that is well known for a long time, especially about amyloid. That many people have amyloid plaques in their brain, but they are completely functional, and they won't develop any memory problem at all in their entire life. So we still honestly don't really know why this is happening. But I think that we start to understand that it's about the disease as a whole. We should really have more a holistic approach when trying to understand why the patient have a specific symptom.
Okay, thank you for clarifying that. This is just all complicated, and like I said, I don't always understand everything that I hear, and I'll take bits and pieces there. But I have a lot of conversations with others that are just as confused as I am with all of this. So we appreciate the work that you're doing and taking the time to explain it to us. So whereabouts are you at with your trial? Do you have people in the study right now, or are you just getting ready to launch it?
We have people in our study right now. Our study is a multicentric one. It's running in the UK. In Israel and in the Netherlands. In total, we have 12 hospitals working with us, some of the main hospitals in the region that I mentioned, in London, Southampton. So we cover pretty well UK, Israel, and the Netherlands. We just finished the enrollment of the first cohort. As I said before, we have 5 cohorts in our study. And in each cohort, we plan to enroll about 8 subjects. So we just finished the enrollment of the first cohort. And the way our study worked is that we inject the drug every 3 months. And actually, I said before, safety is the main goal when you start to test a drug in humans. And this is one of the major difference compared to other approaches that are right now developing, right? Especially when it comes to infusion. And again, in my clinical practice experience, for a patient, especially with a disease, going to the hospital is always a stress. It's take him out of his familiar context. He feel lost. So it's very common to see patients behaving worse every time they need to go to a hospital, regardless if they had an infection. It's just take them out of their context. It's not, in my experience, and I think the experience of many patients and family members, it's not that easy. So actually, we are only injecting the idea, our drug, 4 times in a year, which is much less than what is done by other approaches. And it's also very much different compared to what is done in other diseases that use our same family of molecules, right? So, for example, I forgot to mention, and sorry that I'm diverging a little bit, this approach of using the immune system to fight another disease, it's something that it's well established in the field of oncology, okay, in cancer. So, for example, cancers such as melanoma, lung cancer, that for many years, decades, we thought that we had no treatment for them. And now, thanks to immunotherapy, which is exactly what we are trying to do right now, we have a way to treat these patients, and the results are really amazing. So another thing that we should consider is that this drug that we are trying to develop for Alzheimer's is not the first time that is used on humans, okay? It's actually, we already have experience on other disease, and we are learning a lot. We learned a lot from other experiences, which will also allow us to improve the safety profile of our treatment as much as possible. So we are delaying the infusion. We modified our antibody specifically to reduce the risk of immune reactions, so of side effects. So this is more or less where we stand. We have a long way to go. The study is planned to be complete around mid-2025. This will include multiple dosing for all the 5 cohorts. But we will have additional time points along the way in which we will start to look and see if indeed our approach is doing something on the immune cells and on the brain.
Great. So when you talk about infusions, and I agree with you, going to the hospital, nobody likes to go, and then you add dementia onto it, it gets more complicated. Can you explain what an infusion is for people so that they understand that it's not just getting a pill or a shot that a lot of times people think they're going to get?
Thank you, Laurie, for making this question and help me clarifying myself. When we talk about infusion, it's actually a drug that is injected in the blood, right? So the patient needs to go to an infusion center and he receive, in Italian, we call it a flebo. I'm not sure if this is the English term. I apologize with our audience. So it's a bag and it's slowly infused. It's slowly injected within our vein. So it's not a single shot that it's done in few seconds, but it's a slow administration of something in our blood system, in our veins. An infusion can last half an hour to 2 hours. It really depends on the amount that you need to inject and the concentration of what you're injecting. And it's definitely the easiest way to achieve high concentration of the drug in a short time rather than a pill, right? If we take a pill, for example, it needs to go through our gut system, our gut, our liver. So there are many steps in which the drug can be metabolized. So if we take something as a pill, there are several steps that this drug needs to go through before reaching the circulation, the blood. When we receive an infusion, the drug is directly infused in the blood, so we achieve high concentration in a much shorter time.
Well, this is exciting. I would love to have you back once your study is done to learn more about this, because I'm with you. I believe the immune system really is a magic key to so many things. We're seeing it all the time, and we're hearing more and more about the importance of this mechanism within our body and the power that it holds. I love that you're able to go through the blood system to get to the brain, because I remember hearing about the blood-brain barrier and trying to get through that, and they finally did with the nasal sprays and stuff. But to be able to get kind of that equipment that you're infusing into people throughout the body, I would think it would be helpful as well. Just getting all the actors, in the right spots for that. So yeah, exciting times. Is there anything else that you guys are developing, or this is kind of your primary project?
For Alzheimer's disease patients, this is our primary project. First, again, a step back. I will be very happy to come back anytime you want me, Lori. So feel free even before the study will finish. And about our approach, so in preclinical study, we tested several potential ways to harness the immune system to fight Alzheimer's disease. And we found out that the approach that we are testing right now was the most efficient. So for Alzheimer's disease, this is our major goal, our major target, and we are putting all our efforts on this specific drug. What we are testing right now is the potential of this approach, so boosting the immune system also in other pathologies, including other form of dementia, right? So, and again, this, I think, is one of our strength points. We don't target amyloid, we don't target tau, we don't target brain inflammation. We target all of them, but all of them indirectly. So we know that it might work also in other diseases. And actually it was tested already in other disease models of dementia, such as models, for frontotemporal dementia or progressive supranuclear palsy, so other model of dementia, and it was shown to be effective. This is only preclinical study. When I say preclinical study, are studies that are done on in the laboratory, not mostly with mice. So there's a long way to go, but we know that we have the potential to be effective, maybe not specifically with this drug, but with other drugs that still boost the immune system to target other pathology. So this is where we are, our R&D department is putting all their efforts.
Well, nice. I know people with FTD, which is frontal temporal lobe dementia, are going to be excited to even hear that they were mentioned, because I know they feel they're kind of low on the totem pole when it comes to research. A lot of times we hear that from people all the time. So that's exciting news. Anything else that you want to add that we haven't covered?
I think we covered a lot, Lori. So yeah, I don't know if you have any additional question. I hope I was not too boring for you, your audience.
No, you did a great job, and I appreciate you talking in a language that the general population can understand, because not all the time do I get doctors or researchers that can kind of uncomplicate the process so the rest of us can understand. So that is highly appreciated for sure.
I think that's crucial. I learned it in my clinical practice with patients. And you asked me at the beginning why I decided to be a doctor. Really, I think that the impact that the physician can have just by explaining properly what's going on to the patient, dedicating time to the patient to make him feel understood, heard, it's really the first part of any treatment. Even if we will get to, a magic pill for Alzheimer's, which won't happen very soon, as a physician, we still have a lot of responsibility to take care of the patients in a broader way. And I don't know if you are based in the US, right, Lori?
Correct, yes.
So it's not a topic for this conversation. I don't know how things are going in the US, but in Europe, in Italy, I can tell you that there are not enough physicians to do such a complex job, and we don't have enough time to dedicate to our patients. So that's really something, but it's for politicians to deal with it. It's not for us right now.
Yeah, when you were talking about that, I was thinking, and we have to get the insurance companies on to like expand that 10 minutes per patient, because it's not cutting it. But we're feeling the same thing. Healthcare is way low in terms of staffing at all different levels, but we're seeing that in all different industries too, especially since the pandemic now. So, well, I really appreciate your time today, Tommaso. This has just been really, really interesting. And again, I ask our listeners to please like, click, and share this information. There's people in all of our spheres that are dealing with this that haven't told us. And we need to make sure that this information is out there. So when they're ready to talk about it, when they're ready to research, they can easily find it. And so you can be a big piece of that. So be a giver of hope, just like, click, and share so the access is easier for someone in need. Tommaso, again, I appreciate your time today. People can go to your website, which is ImmunoBrain.com, or they can find you at ImmunoBrain Checkpoint on LinkedIn as well. Thank you so much for your time today. This is exciting, and we'll definitely have you back in the future.
Thank you very much, Lori. It was a pleasure to be with you.
Thank you.
Hey everybody, Jared Sebesti here, host of Retire Repurposed. This podcast is dedicated to help people transition into fulfilling and purposeful retirements. Retirement is a big life change. In fact, the two most dangerous years of a person's life are the year they were born and the year they retire. Few people can just flip the switch from working a career 30 or 40 plus years, retiring on Friday without methodical steps to living what we call a repurposed retirement. To listen now, search Retire Repurposed on your favorite podcast platform, Senior Resource, or Life Audio.